أنا اسمي محمد سامح عبداللطيف. أنا critical care consultant في مانشستر في support support foundation trust. هتكلم in the next few slides. بحب طبعا أشكر زملائي الأول for the good introduction، دكتور أحمد زكي، دكتور محمد الختصين. أنا بس هتكلم على الهيمودynamic management of these patients اللي هم a bit tricky. هنتكلم على differences between the COVID patients and a normal septic patients لما بيجوا في البرزنتيشن بتاعتهم، وده هحطه في الكونتكست بتاع surviving sepsis campaign guidelines. فالعيانين الكوفيد patients بيبقوا عندهم مش شوكت قوي، فبيبقى ما عندهمش delayed capillary fail، ما بيبقوش mottled للدرجة دي unless they are very much old age. They may or may not actually have a high lactate, but majority of them have lactate is not very bad unless they are dehydrated pyrexial. Next slide. طبعا كلهم بيبقى عندهم temperature, tachypnea, PO2 FiO2 ratio بتبقى low, heart rate on the higher side, but hyperglycemia may or may not happen actually. Diabetic, yes, they can come in DKA, but otherwise not. Next, please. Leukocytosis is not a common feature. 67% according to the JAMA study below don't have any. ده برضه اللي احنا لاحظناه. They come with a normal white blood cell count, but they all, 2/3 of them at least are lymphopenic. They have high CRP. They don't come with the thrombocytopenia, and only 20% can come with a liver hit. So they may or may not actually find the high NR. Next, please. Again, as I said before, they are not shocked on admission. Okay, so most of them have a normal blood pressure, but they are oliguric, and I'll come back to this later. على الأوليجوريا لأن again the fluid balance is very important in this patient. I think Dr. Muhammad al-Husseini touched on that, but I will touch again on the oliguria and acute kidney injury when I talk about the fluid balance. عندنا على الأقل 2 عيانين في ال ICU بتاعنا جالهم إيليس. Altered mental status, not that common and on presentation. Next, please. Talking about the pathophysiology. Next slide. Thank you. Next slide. Of course, it is a dysregulated host response. So the cytokines involved, the complement system, the vasoactive mediators, and the coagulation cascades. Next slide. So, as I said before, the vasodilatation happens, but not to a great deal, actually, so they don't come in shock. The loss of endothelial barrier definitely happens, and they come with a lot of interstitial lung edema. As we know, capillary occlusion happens, so there is a well-known thrombotic phenomena in these patients, and it manifests itself in the lungs with increasing shunt, but also only last week there is a lot of reports of young patients, 30s and 40s, come up with strokes actually. So it is a known factor. Impaired myocardial function doesn't happen quite a lot, but the impaired myocardial function does happen in about 1/3 of the patients. According to the JAMA study, it's about 33% of the patients. Next slide. From the management point of view, I think, next slide. Thank you. It's as any other patients, actually, it requires early recognition and a treatment, which does not happen a lot in these patients. Don't forget that these patients usually present about a week after the start of the illness because they are asymptomatic in the first few days. Prevention and support of the organ dysfunction, that's the main thing that we can do for these patients, the prevention and support of organ dysfunction. When we come to the rapid source control, again, all the studies talking about the source control, whether treatment includes hydroxychloroquine and azathioprine, the antiviral drugs, and all these sort of things, I think they are not proven yet. I know in Egypt, the friend of mine actually told me they're using it, but actually there's no randomized control trials about the benefit of these medications. Thank you. Next slide. So main causes of hemodynamic instability in these patients fall under 4 categories. Septic shock, and that happens only in 20% of the patients. It also due to cardiogenic shock, and as I said before, it happens in 33% of the patients. Acute copulmonary, 20-25%, and cytokine storm or viral shedding. and it's a well-known phenomena in these sort of patients. Next slide, please. So what should we do? Fundamental rules is control the cardiac outputs by the preload, afterload, heart rate, and maintaining contractility. You press the next, please. And that's mainly by controlling the fluids, the vasopressors, maintaining sinus rhythm, which is very important in these patients, and giving inotropes. Next slide. The whole idea, obviously, is maintaining the oxygen delivery to the oxygen consumption balance. Next slide. Keeping in mind all the time that hypotension, or if these patients come to this sort of low blood pressure, keeping them on the hypertensive side is very, very ominous. The mortality rate actually rises quite significantly, and we have to maintain the arterial blood pressure above 65% as early as possible. Next slide. So in any interventions that I will talk about it in the next 5 minutes or so, we identify the problem, choose, monitor, measure indices, and then assess the target. Continuous assessment is very important. Investigations to start with is what I advise everybody to do is ECG, echocardiography is very, very important in these patients. Lung ultrasounds proved to be important also in COVID patients, and TROP-I. Let's talk about the septic patient to start with. The first thing to do with the septic patients is the treatment with fluids. If you look at the Survivor Success Campaign guidelines, basically they said conservative fluid management. I think Dr. Mohammed Husseini touched on this before, in the sense of, because they said conservative fluid management, a lot of people actually kept them on the dry side. And this is what they didn't mean that. They mean them keep them euvolemic. Because let's face it, these patients are pyrexia, dehydrated, tachypnic, they are fluid, and they have acute kidney injury. If you run them on the dry side, they probably go into acute kidney injury and renal failure. And that led to the initial cohort of these patients. A lot of them were being on renal replacement therapy. I think the reports from King says 1 in 3 patients went into hemofiltration. Next, please. No, just next slide, sorry. Yes, so basically they recommend crystalloid rather than colloid to start with. No starch, and also, next, they recommend actually don't give albumin in the initial period of resuscitation, but albumin has a place if the initial crystalloid didn't work. Next, please. So the aim is with the survivor is to start 30 mL per kg within the first 3 hours. Having said that, it's unreasonable. Next, please. It's unreasonable to leave them for 3 hours with no fluid. So it needs continuous assessment, obviously, for these patients. And the usual regime that I would like to demonstrate here is from a French study. Next slide, please. And this French study actually nailed it on the head. This study was done in 2017, 2018, which suits itself to the COVID patients. You don't give too much fluid. You give about 10 mL per kg to start with, and then assess the response. Assess the response, whatever actually resources you have. You can measure the cardiac output, so you measure pulse volume variability, stroke volume variability. You can do the passive leg rising test, whatever. If they are preload responsive, you have to keep in mind that they may have ARDS. If they haven't had ARDS, keep giving fluid bolus. If you're approaching the 2 liters and they are not responding, I think they recommend giving albumin at this stage, which will keep the fluid intravascularly. If they have ARDS, you have to be very careful. If they are not preload responsive, they recommend using the vasopressors early, or doing an echo for these patients, because it might not be just a matter of squeezing them. The heart may be failing at this point. Next slide. Keeping in mind all the time that they are 48% actually will not actually respond to the initial fluid. The aim with the vasopressors is to maintain a mean arterial blood pressure of 65%. Invasive monitoring is very much recommended in these patients. Next slide. Lung water is a known fact in these patients, and they recommend lung ultrasounds. Next. A lot of B points means that these patients have to be dried up. You may have to give them diuretics. You may have to give them albumin and then give them diuretics, these sort of things. Next slide. Myocardial dysfunction. whatever actually you do, if these patients are not preload responsive, I think you have to measure the cardiac output to make sure that you're not missing the obvious, which is myocarditis or myocardial dysfunction or core pulmonale. Whatever you have, I recommend echo to start with, but if you use any other methods, that's fine. What they do not recommend is pulmonary artery flotation catheter. Next, please. This is an algorithm that a lot of hospitals actually, I found out eventually that they're using more or less different versions of this algorithm. So when these patients come through the door, I think the recommendation is just to do an ECG and an echo. If they are septic and they have normal ejection fraction, you go along the fluid balance that the fluid treatment and the vasopressor pathway that we just mentioned with the last few slides. If the ejection fraction is low, they obviously have some sort of cardiogenic shock. Troop I will be the next one, and if it is high and they have regional motion abnormalities or specific ECG changes, they obviously have ACS, and you should be giving the treatment for that. If they have global changes in their echo and non-specific ECG changes, that's most probably myocarditis, and obviously the treatment will be different. In a minority of these patients, they may get right ventricular strain pattern due to the thrombotic phenomena or due to hypoxic pulmonary vasoconstrictor mechanism, which is identified. And in this case, you have to direct your effort to RV protecting lung strategy with lower driving pressure, lowering the PCO2 below 6.4, prone position, and giving them prostacyclin. So this is more or less what the hemodynamic management actually of these patients in one slide, and a lot of patients doing loads of different sort of things, loads of different versions of this flow chart, if you like. Next slide. So to finish off, and in a nutshell, in hemodynamic management of these patients, you have to be very careful with the fluids. Echo and lung ultrasound earlier on is very, very important. Early invasive monitoring and dynamic variable measurement all the time to guide your fluid management and vasopressor is very important. Don't try to give inotropes before your fluid loading and vasopressors, and don't actually start to give inotropes without an echo and a trope eye, so you know what you're facing really. And overall, you have to look for the global cardiac function. You do an echo, you do cardiac output monitoring, and maybe they obviously mix it venous oxygen saturation, just to give yourself an idea about the global picture. And that's about it, actually. Thank you very much.